All right, let's jump right into this postgraduate level explainer on neuromyelitis optica spectrum disorder, or NMSD for short. For decades, this condition was really misunderstood. It was often just lumped in as a rare variant of multiple sclerosis. But today, we're moving way beyond those outdated definitions. We're going to decode its unique immunopathogenesis and really explore the highly targeted, modern treatment paradigms that have, quite frankly, completely revolutionized patient care and survival rates. So, our agenda for today's clinical review looks like this. First up, NMO versus MS pathogenesis. Then we'll cover the core clinical characteristics. After that, we'll break down the 2015 NMOSD diagnostic criteria, followed by acute attack management. And finally, we'll wrap up with prophylactic targeted therapies.
Okay, starting off with Section 1, NMO versus MS pathogenesis.
For the longest time, we faced this massive clinical dilemma. Because both of these diseases affect the optic nerves and the spinal cord, they were treated basically the same way. But here is the major paradigm shift. Fundamentally, MS is characterized by primary demyelination. NMO, on the other hand, it's an antibody-mediated astrocytopathy. The damage actually begins with the astrocytes, driven by this intense autoimmune response involving Th17 cells and B lymphocytes. So, the demyelination we end up seeing is actually secondary to that initial astrocyte destruction.
So what's the actual culprit here? Well, in about 90% of NMOSD cases, the disease is driven by a highly specific autoantibody that targets the aquaporin-4, or AQP4, water channel. Now, these channels are packed densely onto the foot processes of astrocytes, right up against the endothelial surfaces of the blood-brain barrier. When those AQP4 antibodies bind to the channels, they trigger a devastating complement-mediated cascade. This leads to cytolysis, basically the explosive destruction of the astrocytes, which then sparks massive inflammation and that secondary demyelination we just talked about.
Let's move right along to Section 2, Core Clinical Characteristics.
Bringing this to the clinical front lines, let's look at one of the absolute hallmarks of NMOSD, longitudinally extensive transverse myelitis, or LETM. Unlike the small, kind of patchy spinal cord lesions you typically see in MS, an NMO lesion is huge. It usually spans 3 or more contiguous vertebral segments. And if you look at an axial view, these lesions are often centered dead on the gray matter of the cord. This extensive damage is exactly why untreated NMO can so rapidly lead to permanent paralysis or even fatal respiratory failure if it hits the high cervical cord.
Another core characteristic we have to watch for is severe optic neuritis. You'll often notice this striking enhancement of the optic nerve on post-gadolinium MRI scans. Now sure, optic neuritis happens in MS too, but the NMO variant is just far more aggressive. It's frequently bilateral, meaning it hits both eyes simultaneously, and it can cause devastating, irreversible visual loss. It is not at all uncommon for NMO optic neuritis to leave a patient with a complete loss of light perception if we don't treat it immediately.
All right, here is a massive clinical pearl for your exams and your daily practice. Area postrema syndrome. The area postrema is located right in the dorsal medulla of the brainstem, and crucially, it is incredibly rich in AQP4 water channels. When antibodies attack this specific spot, patients show up with episodes of intractable, completely unexplained hiccups, profound nausea, and severe vomiting. And here's the kicker. This can sometimes be the very first symptom a patient experiences, showing up long before any vision loss or paralysis even starts.
Let's pivot to Section 3, the 2015 NMOSD diagnostic criteria.
So how do we lock in the diagnosis? The 2015 international consensus leans heavily on a patient's AQP4 IgG serostatus. If your patient tests positive for the AQP4 IgG antibody, and by the way, we strongly recommend using a highly sensitive cell-based assay for this, the diagnostic bar is actually pretty low. Because this biomarker is just so incredibly specific to NMO, a seropositive patient only needs one of the 6 core clinical characteristics to secure the diagnosis. Assuming you've ruled out alternative diagnoses like MS or MOG antibody disease, that single attack plus the antibody entirely confirms NMOSD. But what about the roughly 10% of patients who are seronegative, or if you just can't get the testing? Well, then the criteria become much more stringent. You have to methodically prove the disease burden. The patient has to experience at least 2 distinct core clinical characteristics to show dissemination in space. Plus, at least one of those characteristics absolutely must be one of the big 3, optic neuritis, LETM, or area postrema syndrome. And to top it off, all of this has to be accompanied by very strict MRI requirements just to make absolutely sure we aren't misdiagnosing a different condition.
Moving on to Section 4, Acute Attack Management.
Because untreated NMO causes such rapid and devastating disability, again, we are talking about permanent blindness and paralysis here, we absolutely must hit acute attacks hard. Your first-line rescue therapy is high-dose intravenous glucocorticoids. Typically, that means methylprednisolone at 1 gram per day for 5 to 10 days, followed up by a slow oral prednisone taper. But remember, time is tissue in the brain and spinal cord. If the patient isn't responding rapidly to the steroids, you need to empirically and quickly escalate to plasma exchange, or PLEX. We usually do about 5 to 7 exchanges to physically filter those pathogenic antibodies right out of the patient's blood. Okay, I need you to literally etch this next point into your memory. This is exactly why distinguishing between NMO and MS is a matter of profound patient safety. Giving standard multiple sclerosis disease-modifying therapies, drugs like interferon beta, fingolimod, or natalizumab, to an NMOSD patient is not just ineffective, it can actively and dangerously exacerbate NMO relapses. I mean it. A misdiagnosis here can literally trigger the exact paralyzing attacks we're trying so desperately to prevent.
And finally, Section 5. Prophylactic Targeted Therapies.
To prevent future relapses at all costs, we essentially translate our understanding of the immunopathogenesis directly into prophylactic treatment. It's a perfect mapping of mechanism to medicine. We can target the B cells driving the antibody production using anabilizumab, which is an anti-CD19 monoclonal antibody, or we can use the older empiric therapy rituximab, which targets CD20. We can block the inflammatory cytokine cascade using satralizumab, an IL-6 receptor blocker, or we can just halt the explosive astrocyte destruction right at the source using terminal complement inhibitors like eculizumab or ravulizumab. Because of these incredibly targeted therapies, the 5-year survival rate for what used to be a uniformly devastating disease has climbed to as high as 98%.
We've seen how identifying just a single water channel, AQP4, completely transformed neuromyelitis optica from a misunderstood, misdiagnosed MS variant into a highly treatable astrocytopathy. It really is a stunning victory for neuroimmunology. But, it leaves us with a pretty provocative thought. As we walk the wards and look at other devastating, currently idiopathic conditions, what other neurological mysteries are just one precise biomarker away from being solved? Thanks for joining me on this Clinical Explainer. Keep asking those big questions, and I'll see you next time.